I'd like to introduce our two primary presenters today. First of all, Frances Glascoe. She'll be the second presenter. Frances Glascoe is the adjunct professor of pediatrics at Vanderbilt and at Penn State Universities. From 1987 to 1999, Dr. Glascoe directed the rotation in child development for interns and medical students. Her research focuses on the accuracy of many different developmental and behavioral screening tools. She is the author of more than 100 papers in peer-reviewed journals. Dr. Glascoe is author of the Parents' Evaluation of Developmental Status, known as the PEDS, a brief screen for developmental behavioral problems in children 0 to 8. The Safety, Word Inventory, and Literacy Screener, and she's a co-author of the Brigance Infant and Toddler Screen. She presently presents frequently at meetings of the American Academy of Pediatrics and the Ambulatory Pediatric Association. For 8 years, she's been the North American editor of the Ambulatory Child Health, the Journal of General, Community, and Social Pediatrics, and she currently serves as an editor on the boards of the Archives of Pediatrics and Adolescent Medicine, as well as the Journal of Developmental and Behavioral Pediatrics. I know you'll enjoy her comments today.
I want to start out by telling you what's in your handout, and then we're going to talk about some of the issues and challenges of early detection, and then I'm going to provide some solutions and hopefully have lots of time for question and answers and discussions of implementation issues and logistics. In your handouts, the thick bunch of papers you have, is an outline for this talk, information, a table about quality screening tools, how to get them, what they cost to administer. There's a section on diagnosis and procedure codes for billing, information about patient education resources, tips for interpreting screening test results to families, information on how to organize an office for efficient screening, a guide to leadership for offices and colleagues, a list of warning signs for autism spectrum disorders, and referral resources for Minnesota. There's some additional things in the screening kit that you'll get at the end. Now I want to talk to you about some of the forces that are really driving a heavy interest in screening. First of all, Medicaid in the Early Periodic Screening, Diagnosis, and Treatment Program requires comprehensive health, developmental, and mental health screening. Currently, there are 28 states that are the target of class action lawsuits for failure to comply with Medicaid regulations, and Tennessee just settled theirs and became the first state to require standardized, validated, accurate screening to be administered at every well visit. 2 years ago, the American Academy of Pediatrics came out with a statement about developmental and behavioral screening and again recommended standardized routine screening at every well visit. Recently, the American Academy of Neurology came out with a statement about screening specifically for autism that parallels what the Academy wrote but adds a little bit more. And in addition, we have the Individuals with Disabilities Education Act, or IDEA, which has child find and early intervention services and has been a mandate since 1975. The rationale for all of these are several. One is that the primary care provider is really the only professional in contact with families with some knowledge of development and thus in a position to detect problems. The second one is that we know that early intervention works. There are many, many longitudinal studies showing higher graduation and employment rates for children who have been through early intervention, reduced teen pregnancy, reductions in criminal behavior and violent crime. And for kids who continue to have disabilities after high school graduation, they are still far more able to live independently and to be productive citizens, to earn money, to be employed. For every dollar that we spend on early intervention, we save 7 as a society. Most physicians are fairly aware of the value of early intervention and supportive of it, but here's what we find when we look at detection rates of developmental disabilities in primary care. 70% of children with developmental disabilities are not detected by their primary care provider. Rather, it's not until they get to school, kindergarten age and later, that their problems are detected, and by then they've missed all opportunities for early intervention. And it's even worse when we look at mental health problems. At least 80% of children with mental health problems are not detected. So why does this happen? And let me show you about 5 major challenges that seem to intervene in our ability to detect kids adequately. The first one is our heavy dependence on the use of informal checklists. These are often embedded into age-specific encounter forms, so there might be a slightly different checklist for every visit. But let me just have you do this exercise with me. If you say this is a sample checklist that might be on the encounter form at a 5-year visit. Just try this. Look around the room and raise your hand in response to this question, but look at your colleagues and see what they're doing. You have these 6 items. What if you have a 5-year-old who can't do one of these 6 things? Would anyone refer? Okay. What about 2 of the 6? Would anybody refer if a child couldn't do 2 of these? Right, hands up. Okay, some. 3 of the 6? Okay. 4? Okay, got most of you by now. Okay, now if you looked around the room, what you saw was that hands went up at different times. So my question is, who's right? And the next question is, who knows? This is not a validated tool. There are no clear criteria, and every single person has a different set of solutions. And similarly, what if your child can do all 6 of these things? Do you know that he or she is okay? You don't. There's no proof. We don't even know that these are pretty good items, and I would submit these are items from the Denver, which misses 50% of children with developmental problems, that this is not a particularly good tool just going into it on the item basis alone, but setting the criteria and knowing what to do on the basis of this information is not clear. And you know, in medicine we measure many things. We measure height, weight. In developmental clinics we measure ear length and the distance between people's eyes. Well, here we leave the most important aspect of our lives to chance, and that is developmental status. A second challenge is how we communicate with families. We often depend on families to raise concerns to us, or we ask them questions, but many times the questions that we ask are not particularly effective, this being something of an exaggerated example. But even some of the simple things that we ask families, like, do you have worries about your child's development? Do you think your child has any problems with development? It sounds like a reasonable question. You've probably heard it or asked it yourselves. But only 2% of families will respond to that question. The prevalence of disabilities is 16%. So that's not cutting it. Why doesn't that question work? Well, when families first start to notice that a child may be having difficulties, they observe them more carefully and they wonder and they have concerns, but they're not sure that they're worried yet. They're not sure that these are problems. Those words are ominous and families will not endorse them. Also, 50% of families do not understand the word development when used in isolation. And then when we have, you know, busy schedules, tight time frames, fatigue at the end of the day, I've seen attendings and residents walking with their hand toward the doorknob. You're not concerned about its development, are you? No family will answer that question at that point. So standardized quality tools get around that by asking questions that are proven to work. That's what test construction does. They test these things and they know that the questions work well and elicit information that we want to have. A third challenge is our tendency to rely on clinical judgment and perhaps not to recognize the features and facies of children with developmental problems. We would all recognize this child and this kind of disability. She has obvious dysmorphology. But what about this child? What's wrong with him? Well, you can't tell by looking, but his IQ is exactly the same as the child in the slide before. He has mild mental retardation. He has a static encephalopathy. He has a mild gait disturbance. He walked on time. He doesn't walk well. But discriminating what is walking well from not walking well requires measurement. These problems are too subtle to be detected by observation. This well-behaved little boy walked on time, walks well, talked on time, does not talk well. He has a speech-language disorder. He has mild pervasive developmental disorder. And trying to discriminate what is talking well from not talking well is challenging, and he is yet another child who is not detected in primary care. This child walked well, talked well, went through his whole early childhood years without any glitches, but got to school and had trouble reading. He has a learning disability in reading. He's well behaved during this physical exam. His ADHD symptoms were not apparent because his behavior was restricted. So he was missed on both his learning disability and his ADHD on the basis of clinical judgment. Measurement is needed. A fourth challenge really has mostly to do with the nature of development itself. This is a normal child, but will she be at 16 months if she's not using words, or at 24 months if she isn't putting words together? Development develops, developmental problems develop, and we have to continually look at how kids are doing. Also, development in even children who are normal for long periods of time can be derailed by psychosocial risk factors. And in this slide, what you see on the y-axis are IQ scores, and on the x you see a number of psychosocial risk factors. And these include things like parents with less than a high school education, more than 3 children in the home, stressful life events including frequent household moves, a single parent, parents with mental health problems including milder things like depression and anxiety, substance abuse, less than responsive parenting. And you see these families in your clinics. These are families who bark orders at their children, don't really pick up on their child's interests, and engage in that high-pitched, repetitive, sort of middle-class kind of parenting language to children. In infancy, these are parents who will talk to their baby when their baby's crying. Don't cry, don't cry. But when the baby stops crying, he's back on the shoulder, and so he never gets a chance to see reciprocal language and interchange, and so language skills aren't built. Poverty has a dramatic impact on child development, limited social support, families who live in isolation, and very last in this regression equation that predicted developmental outcome was minority status. And probably the reason it loaded here is because ethnic minorities often have many of these other risk factors. What happens is you get 4 or more of these risk factors and you get a sharp drop in IQ. Now notice that it drops down to the 16th percentile, and you may be thinking, well, 16th percentile, that's normal for height, it's normal for weight, but it's not a good place to be for development. If this is a child in a classroom with 30 kids, how many are at the 16th percentile? 1 or 2. Instruction will go over this child's head. Instruction is set in a narrow range between about the 30th and the 60th percentile. So this is a child who will fall further and further behind. This is a child who will probably get retained in grade, who will, as related to that, is more likely to drop out. And then all these risk factors just start all over again. What this means, though, is that development is malleable, and early intervention works by taking away these risk factors for part of the day. And it's one of the reasons we get dramatic increases in language skills and academic skills, and often in IQ. But it also means that development is a moving target, and only if we use quality tools and only by looking repeatedly are we able to see when children get off track and when they really need assistance. One of the more amazing challenges to me is how we deal with the results of screening tests. And this first bullet here is from a study that appeared in Archives of Pediatrics and Adolescent Medicine last May. And physicians were given the results of a screening test, the Pediatric Symptom Checklist, which is a very accurate mental health screen that identifies children with significant, potentially significant mental health problems. Physicians were given the results. The researchers just looked at what happened next, and what they saw was that more than 80% of children with a high likelihood of a significant mental health problem were not referred. And they were also not referred if they had evidence of developmental problems. Well, why is this? One reason is that most referrals out of primary care are made only to services with which providers are familiar. So if you don't know much about the mental health community or the early childhood community, you're not very likely to refer to them. And in some ways it's understandable, but it's a problem. And one of the reasons it's understandable is that non-medical professionals don't always respond to primary care providers in the way that you'd like. They don't respond to you the way subspecialists do, by calling you back, jogging your memory about the patient, telling you what the results are, and engaging in a collaborative decision-making process about what happens next. Often when you refer to early intervention, it feels like a runaway train. You don't know what happens to your patient for a long time, and then the family comes back and the child's enrolled in occupational therapy, speech therapy, all these things you didn't authorize. They may be a financial burden. You don't have buy-in. You don't know if it's really important or valuable. One of the things that we've been doing in this training is trying really hard to get the early intervention people to understand that this is a problem and that they really need to call you back, tell you what the results are and engage you in joint decision making about what happens next. It also serves as a pretty nice reminder, makes it more of a friendly, comfortable referral process, and means that it's more likely that you'll refer in the future. Now, if we actually use quality screening tools and we know our referral resources, these are the kinds of detection rates you can expect, that 70 to 80% of children with developmental disabilities can be identified in primary care, and 80 to 90% of children with mental health problems can be identified. These aren't perfect. This isn't great if you're thinking about a tuberculosis screen or an AIDS screen, but remember we have this moving, malleable target and developmental problems developing. So this is pretty good for one-time screening. We anticipate that over time you would get much higher detection rates. But we know that as a consequence there should be over-referrals, and it is okay to over-refer. It is better to over-refer than to under-refer. And as one pediatrician said, think refer, 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 not defer, defer, defer. What we know about kids who are over-referred on the basis of screening tests in primary care is that they are kids who tend to score in that below average range, who have IQs 85 and below the 16th percentile. Their language skills are also at that same area. Their academic skills are at the same area. And those are critical skills, the strongest predictor of success in school. The over-referred kids also tend to be the kids with psychosocial risk factors. So when you over-refer them, what happens is that they're not going to qualify for special education intervention, but the providers there will try to get them to early Head Start, daycare centers, get their families some good quality parent training, may link the children up with after-school tutoring, mentoring, summer school, remedial programs in the school, all things that they need to have. There are a number of other reasons why we don't see routine, standardized, validated screening in primary care with much frequency. One of the first reasons is that the measures that we're probably trained on and know best, things like the Denver, really take too long. If the average well visit lasts only about 15 minutes, having a 20-minute Denver is not exactly workable when you have a physical exam, an ear check, safety and injury prevention, counseling, developmental promotion, and all the host of other things that are important to talk about. You can't spend 20 minutes screening. It's also pretty challenging to think about trying to elicit children's behavior in primary care. They remember you gave them a shot last time. They're scared. They're as likely to throw those blocks at you as they are to stack them. With infants, they may be asleep, they may be cranky, they may be wet, they may be hungry, and even though it's a well visit, it's really hard to get decent cooperation out of them. Reimbursement is certainly limited, so spending a great deal of time on screening is not sufficiently lucrative to cover salaries and overhead. And of course, we have concerns that we're going to alarm patients unnecessarily or their parents. Sometimes we think delays will improve on their own, but really the number one complaint I get when I do these talks is, well, this is all well and good and I think I need to use a better tool, but there's nothing out there. There is stuff out there, and so one of the things we'll be talking with you about today and is in your kit are how to reach these referral resources. And in Minnesota, it's really easy, and they are out there and in abundance. There is something for everybody in this state. All this means is that we really need tools that work about like this. And in reality, there are some things that pretty much do, and these are the newer screens that are briefer and accurate that tend to make use of information from parents. These are tools that you can use in the waiting room or you can use in the exam room. You can send home with an appointment reminder and have the parent bring it back in or mail it to you. There's a lot of flexibility. You can do them over the phone. You can do them by interview. The families can fill them out on their own. And what it does is shift the time that you would have spent trying to get children to demonstrate behavior, freeing you up to do more patient education, developmental promotion, and more the intervention work of primary care, which is just critical, and gives parents a chance to express themselves. They have downtime during an office visit. They sit in your waiting room for quite some time often, or they sit in the medical exam room for quite some time. So put them to work. They want this task. They're happy to talk about their children. But it does lead to several questions. One is, can parents really read well enough to fill out the screens? And usually is the answer. Not all can. But it means that if you try these tools in primary care, you really have to get your office organized. Somebody, preferably the person who hands out the screen, needs to ask the family, can you fill, or would you like to fill this out on your own, or would you like to have someone go through it with you? So that those parents who are not literate can opt out. Not all will. But if you don't do that, what happens in one study, 50% of Spanish-speaking families just disappeared their screening forms because they were embarrassed that they couldn't fill them out. Or you'll get parents who will just randomly circle yes, no, or a little, and it's hard to tell if they really did understand what was going on. Poor readers often skip items, so you need somebody to look at the response that comes back just in case the parent didn't take the opportunity when offered. To have somebody to look at the screen to make sure that it was filled out right, and to offer an interview when that seems to be indicated. The second question is, can parents really give us accurate information? And the answer is yes, that screens using parent report are as accurate, and in many cases more accurate, than the measures where you actually elicit behaviors directly from children. A broader question is, can all parents use these tools? I think a lot of times in primary care we see that educated parents raise concerns, and we feel like they notice things about their children, and it makes us wonder if ethnic minorities and poor parents really are observant, or maybe they're more in denial, or maybe they don't really notice. It's not really true. What we haven't done with that group is ask them effective questions. And so the standardized tools, because they're tested and because they have psychometric support, test for this specific thing. And what they show us is that parents, despite differences in levels of education, parenting experience, if they're talking about a firstborn or a laterborn, are equally able to provide accurate answers to these tests given good questions. And the tests have mechanisms for correcting for the tendency of some parents to over-report. Parents certainly see children in familiar environments where kids are much more likely to demonstrate skills than they will in an unfamiliar place. And screens have mechanisms for making sure that parents report on mastered skills rather than the beginning to and emerging skills. So let me talk to you now about 4 tools that you can use in your office. These are frontline, broadband screening tools that can fit in the time constraints of primary care and free up some of your time at the same time. The first one is Ages and Stages Questionnaire. These are in your handout. There's a list of all the contact information, the accuracy levels, the prices, strengths and weaknesses for these tools, and I'll try to highlight some of those for you as I go through them. Ages and Stages runs from 4 months to 6 years of age. You buy a box that has all the forms in it, and then you photocopy them. There's a different form for every well visit. It's a little bit expensive because you've got 4 pieces of paper, and in primary care, whoever's copying probably isn't billing or seeing a patient, so it makes this a little bit more expensive than you'd think. But you never run out. They're always in your office. Each of the forms has about 35 items, and they direct the parent to do different things with the child, like have the child draw some shapes, and they have helpful illustrations so the parents can follow along. The ASQ taps the major domains of development, motor, language, and so forth, with the exception of social and emotional skills, and there's a separate measure that does that. It takes parents about 10 to 15 minutes to fill out, so if you have short waiting room times, you might want to have families come in early or mail this out in advance. Some of the individual items, the publisher reports it's written on the 4th grade level, but some of the individual items are much more challenging. So if you use it, you're going to know pretty soon which ones are harder, and have your check-in person read those items to families or make sure that they go through them with them. But working through the logistics of this test is worth it because it's one of the more accurate ones on the market. And once you get the information, the scoring is relatively simple, and you can see how kids are doing in the various domains. These are just a few sample items. You assign a value of 10 to yes, 5 to sometimes, 0 to no, total, and if the score falls in the gray zone, you have a child who you definitely want to refer. Do you have any questions about this tool before I go on to the next one?
Does that cover motor development as well?
Yes. The question was, does that cover motor development? And it does have a motor domain. Fine motor, expressive, receptive, really looks through everything there. This is the child development inventories. Is anyone using these? These were developed in St. Paul and University of Minnesota. They are 3 screens that collectively cover the 3-month to 6-year age range. The infant development inventory is 3 to 18 months. The early child development inventory is 18 to 36 months, and the preschool development inventory 36 to 72 months. Each of them has about 60 items. They're very short descriptions of children's behavior. They can be completed by parents in less than 10 minutes. The author reports that they're written at the 9th grade level. I haven't pulled these items and run them through anything like the Flesch-Kincaid or Gunning-Fogg index, but my sense is that it's easier than that to do. I don't see as much fallout. The items are close together, so you'll see more skipping items with the parents who don't read particularly well. It takes about 2 minutes to score. The infant screen shows you performance in all the different domains up to 18 months. After that, the screens for older children just give you a single score. Basically, they do have motor items, but motor skills are no longer strongly predictive of school success and development in general. So there's more emphasis on language, pre-academics, social skills, and fine motor. So there's not a way to get an even look at each domain. But you can look at the individual items and get a sense, oh yes, this child's having lots of problems with fine motor, language, or so forth, a little error analysis, and that's easy to do. This is just a little bit more information about one of the 2 older screens, 60 items. Here's some sample items. The parent simply colors in a circle to show which ones the child can do. You count the number of yeses and compare it to a cutoff. And if they score below the cutoff, you refer. There are some additional items that aren't scored that really probe health issues, temperament, behavior, crying, withdrawal, sleep problems that are pretty helpful for kind of getting a broader look at some issues that might go along with a possible developmental disability. Any questions about the child development inventories? Okay. The infant toddler checklist, there's a copy of this in the First Signs kit, so you'll be getting an actual copy of this today. This is in the public domain except for the scoring. You have to get the CD-ROM from the publisher. But it's a 24-item multiple choice checklist that spans the 6 to 24-month age level, takes about 5 minutes to complete, identifies a range of disorders, or is known to identify kids who are likely to have those disorders. Was developed by an autism researcher, so it really probes a lot of those things that are associated with the spectrum, the social, reciprocity, language kinds of functions. Does not have a motor component to it. Here's an image of some of its items and the guidance in what to do next. Any questions about this one? Okay. This is Parents' Evaluation of Developmental Status, or PEDS. I need to disclose that I am the author of this measure and may receive royalties on it, but I will assure you it is not a get-rich-quick scheme. It is a runaway train, too, as people use it in different ways for research purposes and all kinds of things. But I developed this after working with residents for a long time and seeing them struggle to communicate with families, and being in a developmental clinic where we heard families say, you know, I told my pediatrician and nobody listened to me. And so really looked at, you know, the fact that in a pediatric encounter we do try to elicit parents' concerns with questions like, what brings you here today? So this measure, unlike the others, elicits parents' concerns about their children's development and probes all the different domains with them so that they learn to think about development like professionals do, as a range of activities. Comes in lots of languages. It's written at the 4th to 5th grade level, so we only expect about 8% to have difficulty in a broad population. The same set of questions for all visits. It takes about 2 minutes to score. With that information, it tells you, identifies 3 kinds of kids. Kids at high risk, the ones who have likely disability and need to go on to specialized early intervention, most likely. Kids at moderate risk, the kids with the risk factors and the below average development who need different kinds of referrals, and kids at low risk, who are 2 types. One whose parents feel like they're working comfortably and things are going well, and then the parents who have concerns want information from you even though they don't have children at risk. There's a longitudinal form, and this measure screens for both developmental and behavioral problems. This is an image of what the form looks like, and parents have to write on it, so you have a pretty quick clue as to whether or not there's sufficient literacy to take the measure.
How long does that take to complete?
It takes between, the question was how long does it take to complete? Between 2 and 11 minutes. One pediatrician said if the family has written on it and flipped it over and written on the back, it's an automatic referral. So the more time they spend and the more concerns they raise, the more likely they are to, you don't even have to read it at that point. But the parents, on the average, 5 minutes to fill it out. And it's quick to give by interview if that's necessary. And we should have a Somali translation in hand pretty soon. I understand that's a big population in Minnesota. We do have Vietnamese, Chinese, Spanish, Hmong, several, and are debating putting it together as a CD-ROM so that parents could hear it. You'd probably have a tape recorder they could tape, and then you could just stack them up and wait for the translator. That's my thinking as of last night. Once you have the parents' concerns, there's a longitudinal score and interpretation form that remains in the chart. The columns are the well visits according to age. The shaded boxes are the concerns that are significant predictors of developmental problems. The non-shaded boxes are the concerns that parents have that don't predict developmental problems, but for which they need some advice. And you simply total the numbers of concerns, and it directs you to the back of the form, which is an interpretation form, and gives you evidence-based decision support about what to do next, and a little spot to sort of track your decisions and keep track of what you've said to parents all the way along. With this and the substantial amount of cross-validation studies that support it, PEDS will tell you how to make this broad range of decisions accurately. It tells you where and when to refer. It also encourages you to use your clinical judgment and the results of your physical exam, your knowledge of the family, to enhance the decision making. So you can add to the referral process with things like mental health, audiology, occupational therapy, but it does a broad sort as to whether children need a speech and language evaluation or psychoeducational evaluation. In other words, IQ testing, adaptive behavior, academic skills. It tells you when to screen further or to refer for screening, when to offer developmental promotion, which parents need that kind of help being enriching parents, when to provide behavioral guidance, when to observe vigilantly, to wait and see but with extra looks at how the kids are doing, and when reassurance and routine monitoring are simply sufficient. As the author, I get a lot of feedback about it, and one of the things I'm hearing is that the use of PEDS and the elicitation of concerns in advance of the actual encounter reduces doorknob concerns, and those are really things you don't want to have happen. As one pediatrician said, referred to them as the grenade of the day. Often the grenade of the day are very significant developmental concerns that have a high predictive value of meaning something, but when they come up at the end of the encounter and you've mentally checked out and you've got a waiting room full of patients, you either rush to deal with them or invite the family to come back or dismiss them sort of, you know, well, let's worry about that next time, or that's not a big deal. And if you try to address them, patients stack up and people complain, and you know that's a problem too. So by asking the questions about concerns in advance, you reduce the likelihood of the doorknob concerns coming up. It enables you to focus the visit. You have more teachable moments with families because you're addressing what they want to know. It is shown in several studies the use of PEDS to improve parent satisfaction and positive parenting practices. Practices who use this find parents are more likely to use timeout rather than spanking with kids. Any questions about this or concerns about it? Okay. Let me tell you now about 2 autism-specific tools that are in your kit today that you would use as a second stage tool when you had concerns or a failing score on some of the others. Some practices won't find they have time to do a second tool, and the early childhood folks are prepared to use these, so you can refer specifically for these. The Modified checklist for autism in toddlers, or MCHAT, is a brief 23-item screen. Identifies 4 domains on the spectrum from other children in the areas of joint attention, social relatedness, communication, and motor activity. Can be done as a phone interview, takes less than 5 minutes, written at a fairly low reading level, and comes in English and Spanish. Here's some sample items. Does your child enjoy being swung, like playing peekaboo, have interest in other kids, pointing, pretending, and a lot of the communicative intent tasks that you saw in the video. So let me summarize here. The screening process has basically 7 steps to it. The first is that you would conduct routine, broadband, accurate developmental screening in your practices with every child at every visit, and at the same time make some observations about the child's behavior, referring to early intervention if the child fails the screen or if your clinical judgment suggests that they need to go. Performing lead screening and audiological screening at the point that you refer them, and if the behavior indicates an autism-specific screen. And if there are concerns from any of that, going on for a diagnostic evaluation. In most states, it's not necessary to have a diagnostic evaluation to be an early intervention, often until they're up to 5 years of age. But with autism, it's better to go ahead, get them in early intervention, but go ahead and get a good look at what's going on, because intervention for these children is very specialized and very different. So want to get that diagnosis early on this group. Referral resources are in your kit, and there's some clear numbers to call in this state. And just the bottom line is that I want to remind you that early intervention works. Your role in this process is critical, and the use of quality tools is really essential.